tend to forget this. Let's see here. So cancel. Sorry. Okay. So sometime in the next week, I will re-listen to each of your presentations, and then I grade them according to the rubric. And then I will also grade your budgets. So you'll get more individual feedback from me, in that way. So you'll be hearing more from me. Okay, so my name is Catherine Schrag, and let's see, I'm a CNM and an FNP, although most of my practice has been in women's health as a full scope midwife. I am one of those rare people, I think it's kind of rare, that really likes the business side of healthcare. I had no idea I would, but I do. And I have taught in the role courses at Frontier since I joined the faculty about 13 years ago. Up until a year ago, I was also the RCF for Women's Health and Midwifery for the West and Southwest. So I recognize Katie's. Hi, Katie. But I resigned from that position just a year ago. I almost retired, but then I decided I wasn't quite ready to retire. So this is the only course that I'm teaching at Frontier right now. I live in Southern Arizona. I am actually right this minute outside Portland at my parents' house. And I don't want to tell you all, they're 94 and 95, and they're a little confused. So I told them last night, which they won't remember, but I left them a big note this morning. It's early here. It's not even 8 o'clock, saying that I was in this bedroom and that sounded like I was talking to people and they would hear voices, but it was really only me, and I was talking through the internet, and it's really hard for them to understand that. So if some sweet little old people walk in the door, it's my mom and dad. What else? I want to say one more thing. I do not have a doctorate. So I don't have a DNP or a PhD, and Frontier has let me stay on in spite of that. So please call me Catherine. Okay, that's enough of me. So the first question I have, let's see, Kathleen, you like to be called Kate, right? Yeah, okay, so Kate, you were the first person to come on, so you get to choose whether you want to present first, second, third, last, whatever.
I can be first or second, that's fine.
Okay, well then why don't you do me first and get it done with?
Okay.
And then I think what I'll do is just, because it's easier for me to keep track if we just do it in the order that you checked in on, not only presenting, but just like right now for introductions. So let's go around the room and briefly, like in a minute, tell us who you are, where you are, where you live, or where you live, and if you're not at home, if you're in another state doing clinicals, let us know that, because for me it's easier to remember where you live than your names, just the way I am, and what program you're in. Are you in the master's program or postmaster's with midwifery, FNP, women's health, or are you in the postmaster's DNP program? Because some of our students are the DNP students, and if so, what specialty of advanced practice nursing have you been in prior? So that's what I want to know in about a minute or so. So let's start with Kate.
Yeah, I'm Kate. I'm in Portland, Oregon, and I'm in the master's midwifery program.
All right. And Carly, where are you?
Hi, I'm Carly. I'm in Erie, Pennsylvania, actually, and I'm in the master's family nurse practitioner program.
Okay, Erie FNP.
Mm-hmm.
All right, and then let's see, Colleen, you were the next one to jump in.
Hey guys, I'm Colleen. I'm from Wilmington, Delaware, and I'm in the master's midwifery program.
Delaware CNEP. Okay, hi Colleen, and then Rita.
My name is Rita Gilbert. I live in Hyden, Kentucky, and I'm in the Family Nurse Practitioner program, the Master's program.
All right. All right. If you have any problems, Sean will just run right over and help you out.
I'm actually just about 5 minutes from campus.
Amazing. Amazing. Sarah.
Hi, Sarah Grable. I am in Fort Riley, Kansas, and I am in the master's program for women's health.
Okay. Kansas. Women's health. All right. And then Ashley.
Hi, I'm Ashley Burden, and I'm in the CNET program, and I live in Kentucky.
Another Kentuckian. Are you having weather?
Yes, we have had
Yeah. Okay.
some storms and some wind. Yeah.
Yeah. Well, Rita let me know this morning that about the weather, and she was concerned about what if I can't get on if I lose power. Obviously, if you lose power and you can't continue, then you can't continue. What are you going to say? So then you'd have to reschedule, which I know you're probably all rather not to if I get this done with. Okay. So let's see. Let me say a few more things, and then we'll do the presentations. I want to acknowledge that this assignment is a lot of work to present a 5 to 7 minute presentation, and many of you probably feel like you have no intention of ever starting an independent practice, and I'm sure there are times why you wonder, like, why do you need to figure out how many exam tables you need? I mean, it truly is a lot of detail, but it's important because you are okay. So you're all master's programs. So you're all making that transition from being an RN to an advanced practice nurse, and it is very likely that at some point in your career, you will have to truly advocate for yourself or an idea that you have to do something new, and to be able to have a big picture idea of why you want it done, what the cost will be, what the revenue will be, and be able to present that in a concise, persuasive, short period of time is a skill that will help you. I can almost promise you that you will use the skill at some point. And if you do your spiel, your presentation well, then the person who's listening, whether it's somebody you're hoping will hire you, or a bank that's going to give you money, or a board of directors that's going to support a new project you want to implement, if you can catch their attention and give them make the case for what you want to do, then they'll go and ask you about all that detail that you spent, hours and hours and hours presenting. So this is the pitch, and as nurses, I think many of us don't have a lot of experience in selling ourselves, so that's why we make you do this. And I think I'm totally convinced it's an important exercise. So the other thing to let you know, as you probably saw it or have learned in doing Google Hangouts before, with this technology, we only see when you're screen sharing, we don't see your face. Okay, all we'll see is your screen, and that actually is somewhat reassuring because in real life, if you were standing up doing your 6-minute spiel, people would see your nervous tics or the sweat coming down your chin or something like that. So we won't see you, just so that you know that. Okay, I think that's enough rambling for me. Let's do these presentations. So everybody, for now, everybody stay mute, except Kate, who's going to present. And just let me know whenever you're ready to start, and I will start timing you. So there's just get your stuff. Yeah. Don't forget to unmute yourself. All right.
Can I ask a quick question?
Of course, of course.
Are you going to cut us off at 7 minutes or just let us go? And then if we go over, you would take off points?
The latter. I mean,
Okay.
if I haven't had this happen, but if you go over like 10 minutes, I'll cut you off. I mean,
Okay.
yeah, but no, I want to hear the whole thing.
Okay, cool. Thanks.
Can
Yep,
you guys hear me?
Yes, we can hear you.
Okay. Let's see. And then
Go to slideshow. Yep, there it goes.
oh, here we go. Is that, can you see I'm not seeing what you guys are seeing, I think.
Yeah, now we're seeing all of the other slides. So
Yeah.
go to slideshow.
Yeah, I can't, for some reason it's not letting me.
Oh, you're stuck.
Yeah. I'm gonna go back out of it and
Yeah, I think you should. It's like it froze up or something.
yeah. Okay. Screen share.
You're all going to be way more sympathetic when you go to your next conference and the person's up there trying to get their slides to work, and and you just see the tension. It's like, oh my gosh, I've got 100 people sitting out there and I can't get my slides to advance.
Okay, do you guys see it now?
Yes.
Okay. Okay, I will start then. My name is Kate Struband. I'm in Portland, Oregon, and I'm proposing joining the Legacy Midwifery Group. I contend that adding an additional midwife will increase the group's productivity, revenue, and their ability to fulfill their mission, which is meeting the needs of our most underserved and vulnerable populations in this county. Portland is found in Multnomah County, Oregon, which is rapidly growing. It's estimated that 111 people move here every day. We are whiter than the rest of the nation and have a much smaller African American and Hispanic population due to systemic racism and atrocious housing practices that were in place until the 50s. We have a higher rate of people living in poverty, with approximately 16% of the people in the county under the poverty level. Our needs are high. We have a high rate of sexually transmitted infections. Chlamydia and gonorrhea are rapidly rising. Gonorrhea is especially endemic in our African American community. And most concerning to epidemiologists in the county is syphilis. We have a very high rate of syphilis that is increasing quickly. So much so that we're now testing all women when they come in labor for primary syphilis, even though they get tested in pregnancy. We have a high rate of low birth weight infants in our indigenous communities. That is a goal of the Healthy People 2020, and you can see in our African American community that rate is over 11%. And then we also have a low rate of women who receive prenatal care in the first trimester, another Healthy People 2020 goal, and that is again specific, worse in our African American and Hispanic communities. Traditionally, midwives have impacted overall health by caring for people in underserved communities, using science and evidence-based practice to affect the health outcomes for those groups, like centering, breastfeeding support, continuous labor support, and all of those things are reflected in the Legacy Midwifery Group mission statement, which addresses the hallmarks and shows that they are have an emphasis in cultural competence. There are 11 midwives in the group. They're considered a specialty clinic within the Legacy Medical Group, which is itself an LLC. These midwives are employees, and so when a midwife comes or goes, the group doesn't necessarily have to dissolve and reestablish itself. They see 12 to 15 patients a day in clinic and do approximately 600 to 660 births a year at Legacy Emmanuel Hospital, where they offer water birth and nitrous and comprehensive midwifery care. Legacy Emmanuel Hospital and one of their clinics are housed in Northeast Portland, which is a rapidly gentrifying but traditionally African American neighborhood. They also have a second clinic in St. Helens, which is a rural community, but that has many of the same needs as its more urban counterpart. They are more racially diverse than the county as a whole. Their clientele, with almost 18% African American population and an over 14% Hispanic population, and they use more, they have more patients who pay with Medicaid than the county in general. Or actually, these are state statistics, sorry. So how can I help them? I propose that initially I would probably not add a lot of patients, but just take some of the burden off the current midwives. So I said no additional births for the first year, but then a birth a month more the second. I would be able to see more women in clinic almost immediately for problem visits, well women visits, antepartum visits, and that would increase the numbers of procedures, diagnostic testing, medication revenue every year. So this looks really good. I would increase the revenue by over $350,000 the first year and $515,000 the second. However, there are expenses. My salary, I took as the lowest salary for a nurse midwife in Portland, and I took the average salary of a medical assistant and took half of that, thinking that I could share an MA with another midwife. Then reception, HR credentialing, admin, I divided those by 12 since there would be 12 midwives, and I increased the cost in year 2 by 3%. I need minimal equipment. They already have the space and all the equipment, so I just need basic things. Operating expenses, I increased by 3% the second year as well. And so you can see my expenses here. So there was a 43% uncollected revenue, which was really surprising to me, and I'm assuming we'll talk about that later. And a 5% margin of error when estimating expenses. I would make them no money the first year. In fact, I would cost them $750. The second year, however, I would make a little bit of money for them, $67,000, and then I assume that every year as I get to be more effective and bring clients back and become better at my job, that I would increase their revenue a little more. So my final thoughts. I want to help the Legacy Midwifery Group impact the racial and economic disparities found in the community of Northeast Portland. I believe that adding an additional midwife will improve health outcomes of this community by increasing access to contraceptive, gynecologic, and prenatal care. I also believe an additional midwife will gradually increase revenue for the entire group and impact job satisfaction by decreasing patient loads. I look forward to learning the art and science of midwifery from such a passionate, professional, and brilliant group of midwives. Here are my references.
All right.
Thank you.
Nicely done, Kate. And you had like 30 seconds to spare. All right, so take a deep breath, relax, put yourself on mute. And after you've all presented, I want to go around the room again and ask each of you whether, in fact, you tend to pursue this idea. Kate, are you going to try and get a job at Legacy? And so or are you all just doing this to graduate and never want to think about it again? So we'll talk about that. And we will talk about some of the money pieces and how much you charge, how much you can expect to collect, and some of that as well. I do want to mention, so one of the things, Kate, that you did really nicely is gave a lot of data supporting why they want to grow a midwifery, grow the practice. And I mean, you gave data for the county and then the state, and you included some goals, like healthy people goals, like, okay, so we're not meeting this or we are meeting this. I mean, some of the things I just scribbled down, and as I said, I will listen to this all more, but like the syphilis rate in the area is 3 times the national average. I mean, that's a big deal, so what can you as an advanced practice nurse do to address that? I mean, and when somebody hears, we're all, I think, basically caring people, and when somebody hears that there is a community need that is a real outlier compared to the rest of the nation, that catches their attention, and they're looking for it. Okay, yeah, we can't have people getting syphilis again. I thought we took care of that. Well, here it comes again, And then one of the things that you did, which I thought was super effective, is you talked about racial disparities, and then in health outcomes, and then you showed that the population of the practice serves about 3 times as many African Americans as the county. So here's a need, and we're already serving this community. So what can we do? So anyway, I thought you did a really nice job of using data to make your case for why the practice should grow. So nicely done. Okay, Carly, would you like to tell us about your brilliant idea?
I would love to. Been waiting all morning to do this.
I bet you have. I probably dreamed about it during the night, huh?
I did. Can you guys see everything okay?
Yep, we can.
All right, well, I will get started then. Good morning, my name is Carly Fatika. I'm a family nurse practitioner student, and today I will be presenting my proposal of adding an additional nurse practitioner to the UPMC Family Healthcare of Edinburgh practice. I reside in Erie County, which is located in northern Pennsylvania. It's one of the largest counties in Pennsylvania with a total population of 278,045 people and consists of 799 square miles. Due to the size of the county, it can make it difficult for people to access primary health care. A community need that I identified was the need for low cost and quality health care. Currently, the poverty line in Erie County is at 17.1%, Pennsylvania at 13.2%, and the United States at 13.5%. Due to the percentage of population in poverty, it's imperative that low cost and quality health care be available to this population. Another community need that was identified was the need for more primary care providers. Currently, the rate of physicians becoming primary care providers is falling, which opens up an opportunity for advanced practice nurse practitioners to fill in the gaps so that the community can have access to primary health care. Erie County currently has a provider-to-patient ratio of 1 to 1,607. Pennsylvania is 1 to 1,007, and the United States is 1 to 1,097. And lastly, I identified a community need for education on modifiable risk factors. Risk factors such as smoking and obesity are considered modifiable by the patients. If the patient has one of these risk factors, it increases their chances of several health complications, for instance, cardiovascular disease, diabetes, or cancer. As displayed in my presentation, a significant percentage of the population, not only in Erie County, but in Pennsylvania and the United States in general, are affected by one of these modifiable risk factors. So it's crucial that education, prevention, counseling, and guidance be given to these patients in order to decrease their risks and promote a healthier community. The mission statement for UPMC Family Healthcare of Edinburgh is as follows. UPMC Family Healthcare of Edinburgh is a primary care facility. It is established under the UPMC nonprofit health enterprise. Our mission is basically to serve our community with outstanding evidence-based, patient-centered, quality healthcare, providing health promotion, prevention, treatment, guidance, counseling, and disease management to all ages. By joining the practice, we would utilize the shared practice model, and with my addition to the practice, we would see an increase in productivity and the number of patients seen. I would practice to my full capacity and would be able to provide health promotion, prevention, assessment, diagnosis, and treatment, and management of chronic diseases, and would be able to do so with patients across the lifespan. The business structure for this practice is a 501c3 or nonprofit organization. It consists of a board of directors. It is considered community owned and would allow for local investments and overall community growth. And it also allows for donations and grants. This slide displays the utilization for years 1 and 2. I came up with these numbers basically by talking with the current office manager and reviewing another APRN's productivity for last year. So for year 1, I kind of took into account the time period where I would not be working at full capacity. So therefore, year one's numbers are 3/4 of the utilization I would produce in year two. The current patient mix of the office is Medicaid at 11%, Medicare at 22%, commercial at 65%, and self-pay at 1%. If a patient were to come in at self-pay, there is a 20% discounted rate for the services, but currently the office accepts all insurances. The total revenue for year one's exams and procedures is $323,143.73. The diagnostics and medications is $3,989.34. And the total revenue for year two exams and procedures is $430,712.81. And the diagnostics and medications is $5,319.85. The total expenses for personnel is a calculation of additional staff. So myself, an additional medical assistant. It also consists of 1/4 of the receptionist's salary, and then also the HR and credentialing is divided among the 4 providers. All the salaries were obtained from salary.com. Expenses within the first year would account for startup equipment like desks and computers. However, since the equipment needed is minimal since the practice is already established and functioning. Operating expenses also include facility expenses, which are shared among the providers. Year two personnel total reflects an approximate of 2% increase in salary based off of performance and peer review. The operating costs have also increased due to the increased need in supplies for the increase in patients that I would see in year two. So basically in year one, there is a loss of $23,226.96. I kind of attributed this loss to my time period not working at full capacity and also the startup costs of licensure, equipment, and office supplies. Year two does demonstrate a profit of $69,989.37. This year kind of reflects my working at full capacity and also doesn't have the additional costs of licensure and equipment. So in conclusion, the addition of another family nurse practitioner at UPMC Family Healthcare of Edinboro would be extremely beneficial, not only to the practice, but to the community as a whole. My addition would help address the community needs and would provide patients with evidence-based, patient-centered, and quality healthcare. And these are my references. And that's it.
Well done, Carly. Nicely organized.
Thank you.
So both you and Kate are suggesting something which is probably a little more applicable to a brand new graduate, which is approaching an existing practice and say, grow your practice and hire me. Mm-hmm. And you may really be doing this, you know. And as both of you have seen, it's not unusual to have a loss the first year, you know, because, you know, as you just said, Carly, you're going to be seeing fewer patients as a new graduate. How much of a loss really depends on the budgeting methodology, the accounting methodology for how they assign expenses. Mm-hmm. So if you're just looking at your direct expenses, like, okay, my salary or my compensation package, which is obviously much more than just your salary, my compensation practice, and I need to hire a full-time MA and I need to hire a full-time receptionist, or there are already 4 receptionists. They think they can manage the increased workload, so I'll just do, like you said, what, 1/4 of the pay, 1/4 of that. And then there's all the other administrative costs. Now, in a huge system like Legacy, like Kate was talking about, it's hard to get a figure on, okay, so if you've got in that department, if there's, you know, 40 or 20 providers or something, how do you find out? But somebody knows what the costs are for all the other indirect personnel. And most practices will assign each provider a portion of that because somebody has to pay for that. And you guys are earning the money. You're the ones who are bringing in the money. And then the whole facility side, the overhead, you know, for the comprehensive insurance and the electricity and the rent and all of that usually also gets distributed, and so it's easy to just think, well, they already have the space, so it's not going to cost any extra rent for me to be there. Now that's true. But if it's a practice where each provider, where they track how much money comes in and how much money goes out for the whole practice, most practices also break that down by providers so they can keep track of how much money is, nurse practitioner Susie bringing in, and then how much is she costing us. So if you have a practice, let's say you have 3 advanced practice nurses and you come in as the 4th and you don't bring any new patients, then the revenue is not increasing at all, but the expense is increasing because there's all your direct expense. And if you don't divide up your share of the expenses, then the other 3 advanced practice nurses are bringing in less money because you're taking a third of their business, right? They're happy because their schedule isn't as busy, but they're making less money, and they're not going to be happy if all that revenue is going to you and you're not sharing the cost of the rent. So you have to really look at it. What is the whole picture? And then how is it impacting each individual nurse practitioner or midwife? And different practices have different ways of doing that. And once you're actually in practice, you'll learn how they're tracking that. Because as I said, somebody is tracking what this is costing, because it is a business. It's not an easy business, healthcare, but it is a business. So, okay. Sorry that I got off on a little tangent there. Colleen, would you like to speak to us?
Sure. Okay, so screen share. Okay, so you can see my PowerPoint, right?
Mm-hmm. Let's see. Actually, before you start, let's see. So who am I not seeing? Ashley, is your video on? Ashley, are you there?
I am up.
Okay, I heard you for a second. Somebody's missing here. 1, 2, 3. Well, no, we're here. Okay, I just want to make sure that Ashley is with us. Okay, I see you now. Okay, can you can hear us okay, Ashley?
Yeah.
Okay, good. Yeah, so keep your cameras on so that I know you guys are here, okay? Okay, so we are back to Colleen. Yes, Colleen, we can see.
And you can still hear me, right?
Yep.
Okay, so I, like the other 2, would like to join the practice where I'm doing clinicals, which is called First State Women's Care. So my statement of proposals, I would like to propose adding an additional provider position to the practice and hiring me as a certified nurse midwife. As a provider with the practice, I plan to utilize my knowledge and expertise as a certified nurse midwife to increase profit and growth of the practice while focusing on the needs of our community. So the community needs of Newcastle County include reducing the C-section rate of women with no prior C-section, reducing the low birth weight rate, and also new chlamydia diagnoses in Delaware. The C-section rate of the private providers delivering at the hospital that my practice delivers at, which is a large tertiary teaching hospital. It delivers over 7,000 babies a year. So the C-section rate of the private providers up to January 2017 was 31.71%, which is almost 10 percentage points higher than the Healthy People 2020 goal of 23.9%. The baseline the 2007 baseline low birth weight rate from Healthy People 2020 in the United States was 8.2%, and the hospital where I deliver at has a rate of also 8.2%. Healthy People 2020 would like to aim to reduce that to 7.8%. And then according to the Robert Wood Johnson Foundation 2016 County Health Rankings for Delaware, there were 568.4 new cases of chlamydia infection per 100,000 people. This actually is in comparison to only 287.7 per 100,000 in the US. So clearly Delaware is not handling chlamydia very well. So the American College of Nurse Midwives offers the Healthy Birth Initiative, which helps providers with tools to avoid unnecessary interventions, including C-sections. The position statement on elective C-sections for the American College of Nurse Midwives includes vaginal birth as being the most optimal for most women and babies, that there are risks with the C-section, including morbidity and mortality. There's a higher risk for respiratory and breastfeeding problems in infants from C-sections. And that women have the right to information of risk versus benefit of vaginal birth versus C-section. And according to ACNM, women cared for by nurse midwives compared to those cared for by physicians have lower rates of C-sections, and as well as lower rates of induction, augmentation, and regional anesthesia, which we all know can potentially lead to a C-section. And then in a comparison of midwifery care versus national data, women with midwives had a 9.9 C-section rate compared to the national rate of 32%. So that could definitely help with the C-section rate. The March of Dimes lists the low birth weight rate risk factors such as premature birth, fetal growth restriction, chronic health care in the mother, inadequate weight gain in pregnancy, smoking, alcohol, and drugs, age less than 17 or older, Black race. So women in midwife groups are more likely to receive education on health promotion and reduction of risky behaviors, which helps with the with lowering the birth weight rate, the low birth weight rate. Women in centering pregnancy groups had better prenatal knowledge. Nurse midwives provide care in underserved areas and to those on Medicaid. So physicians providing care to these groups in many areas are continuing to decline. So this would help with the younger mothers and those of minority racial groups. And then nurse midwives utilize collaboration, consultation, and referral to guide patient care for women with chronic health conditions. So currently under federal law, nurse midwives are recognized as primary care providers. And the Office of Technology Assessment found that APRNs provide medical treatment equal to or exceeding physician care at a lower cost. So this means that we can screen for, treat, and follow up with patients presenting with a new diagnosis of chlamydia for much less healthcare dollars than a physician would. The CDC states that quality reproductive healthcare has the attributes of safety, effectiveness, client-centered care, timeliness, efficiency, accessibility, equity, and value. So these attributes actually match up with ACNM's core values of excellence in evidence and inclusiveness, women-centered care, and advocacy and partnership. So the mission statement for First State Women's Care. At First State Women's Care, we recognize that every woman is unique and your needs come first. Our board-certified physicians and certified nurse midwives have over 80 years of combined experience to meet your needs through all stages of life. From adolescence to menopause, we provide complete care, including routine exams, routine and high-risk obstetrical services, and advanced gynecologic surgery. We are pleased to stay abreast of new technologies and also specialize in other minimally invasive techniques. The legal structure of First State Women's Care is a limited liability company, which is owned by 4 out of the 5 physicians there. Some of the benefits of joining an LLC are that it is protected from personal liability of the owners. So if the company has a loss, it won't directly affect the assets of the owners. And there's less restrictions on profit sharing, meaning that the owners decide where the profits go, based on productivity and such. Some of the disadvantages of an LLC is a limited life. So if one of the owners were to leave, the company would have to dissolve. So while joining this practice as a nurse midwife won't affect me directly from the standpoint of being one of the owners, I will be affected in the fact that the owners will be able to decide how they distribute the profits, and that the company could potentially dissolve if one of the owners decided to leave. As a new midwife, I plan to offer comprehensive women's health care for the practice. So this includes obstetrical care of women from preconception to the postpartum period and hospital deliveries of low-risk laboring women. Gynecological care, including annual exams for women throughout the lifespan, and then a focus on screening women at higher risk for STDs. And then also care or referral for other health problems not being treated by myself. So my budget worksheet, the first year, you can see my total charges, total revenue, including the uncollected revenue and margin of error, equipment costs. So just adding a couple things because like we've discussed, the practice is already standing. So most of the equipment is already there. And then the first year expenses came to a total net income for the company of $17,986. The second year looks like I did a little bit better. So the total net income was $132,000. I got most of my numbers from the office manager at the site, and then a lot of my projections from my preceptor based on, what a first year nurse midwife at the practice would likely perform as far as like exams and different visits and whatnot. So my profit is on the plus side for both years, first and second year. And in conclusion, certified nurse midwives demonstrate the ability to provide safe, cost-effective, and evidence-based care to reduce the health problems in our community. By adding me as a certified nurse midwife to the practice, I strive to continue reducing the C-section rate, low birth weight rate, and chlamydia infection rates within our community while adding profit to the practice. And my references.
All right.
Yeah.
Okay, interesting. And well done. You went over your time a little bit, but so you'd have to work a little bit on conciseness. But so Colleen, would you be the first midwife? I mean, in this proposal, we'll find out if you're really going to do this. But in this proposal, are you the first midwife to be added to a 5-physician practice?
No, it already has 3 midwives.
Oh, it does. Okay.
5 physicians and 3 midwives.
Okay. All right. So you'd be the 4th midwife. Yeah. So far, all 3 of you are looking at adding a new position to an existing practice. And so, I mean, I think one of the things that you did nicely, Colleen, is talk about, so a practice that exists, they need another provider. Everybody's too busy, and let's say they want to grow the practice, not just share the current workload, they want to grow the practice. So they have to decide, do they want another doctor or an advanced practice nurse midwife? And you did a nice job of saying, well, here's why you should hire a midwife, not another OB. And there's pros and cons to both ways, but so, using, you talked about C-sections. So it would be really interesting to know the C-section data for not only the hospital, the admitting hospital, but for that group. What's the doctor's C-section rate? What's the midwife's C-section rate? And are they all on board? Do they all agree that that's a goal, that they want to reduce the C-section, or are they all just fine about it? So, but that is something, you have good data how an advanced practice nurse midwife can address that in a way that a physician probably won't, So I think we have to brag some with, humbly brag, and I think you did a nice job with that. So, okay, Colleen, put yourself on mute and let's hear from Rita.
Okay, can you guys hear me now?
Yep.
Okay. Can you see my PowerPoint?
Yep.
Okay. Oh, sorry. Okay. My name is Rita Gilbert, and I'm a student nurse practitioner, and I live in Hyden, Kentucky. I am proposing to join a local family practice, Hyden Family Healthcare. It is my belief that the addition of another family nurse practitioner will greatly benefit my rural community. Hyden is located in Leslie County in southeastern Kentucky. Hyden has a population of approximately 10,711 people, with 98.5% of the population being Caucasian. After reviewing Leslie County's community needs, I recognize the following as the most significant. Leslie County is a medically underserved area with a provider ratio of 5,510 to 1 compared to 1,040 to 1 among the top U.S. performers. Premature death. This is the years of life, potential life loss before age 75 per 100,000 people. And in Leslie County, that's 15,000 years compared to 5,200 among the top U.S. performers. Full hospital stays, which is 261 in Leslie County, in comparison to 85 in Kentucky and 38 as the U.S. average. And I feel these numbers may be directly related to the high percentage of adult smokers in Leslie County, which is 26% compared to the U.S. average of 14%. Also, 40% of Leslie Countyans are obese compared to 25% in the U.S. overall. 35% of Leslie Countyans are physically inactive compared to 29% of Kentuckians and 20% of the top U.S. performers. Smoking, obesity, physical inactivity all increase the likelihood of heart disease, diabetes, cancer, and cause poor health for those living in Leslie County. We also have a high number who are uninsured, which is 19%, compared to 6.5% or 11%, in the U.S., and a very high unemployment rate, which is 12.8% compared to 3.5% in the U.S. And we also have 38% of children living in poverty compared to 13% in the U.S. overall. Needs clearly identify the need of an additional nurse practitioner to educate, treat, and manage the significant health concerns in Leslie County. Hyden Family Healthcare is in the community's needs. This is evident by their vision statement, which says they are a nonprofit rural health clinic that provides safe, quality, cost-effective, and evidence-based care. Their goal is to manage the health and illnesses of their patients throughout their life by health promotion, disease prevention, health protection, anticipatory guidance, counseling, and disease management. They are a 501c3 organization, which means they're nonprofit. They're controlled by a board of directors and able to receive donations and grants. They also target a vulnerable population case is area. By joining Hyden Family Healthcare, I will utilize the APRN model of care and core competencies by incorporating health promotion, disease prevention, health protection, anticipatory guidance, counseling, and disease management. I will be able to manage the health of my patients and their families across their lifespan. Clinic services include chronic illness care, vaccinations, preventative care, annual exams, diabetes screening care, and education, which includes one evening educational class each month. They also provide treatment of non-emergency acute problems, referrals, sliding scale fees for the uninsured, smoking cessation, and education with one smoking cessation class each month during the evening. And they also have extended clinic hours until 8:30 p.m. to allow access to those who work or who are in school during the day. My utilization projections. By adding myself to this clinic, there will be 3 family nurse practitioners. So I took the total number of patients seen the previous year and divided that by 3, which I came up with 1,700 patients. I feel this number is achievable for a new graduate, and it also gives you a picture of the small rural community that I live in. I took into consideration the most frequent procedures done at the clinic, which are cerumen removal, incision and drainage, and sutures. However, the billing clerk did inform me that there is no separate charge for the sutures and I&D. It's included in the office visit. So the most common labs, CBC, CMP, and TSH, and the most frequently given medications in the office were taken into consideration. And I got these numbers from office at Hyden Family Healthcare. The revenue projections, the majority of the patient population, 50% have Medicaid, 35% have Medicare, 10% have private insurance, and 5% are self-pay. Those with no insurance receive a 20% discount, and usually only about 60% of the remaining amount is collected. Other revenue includes money received from labs and procedures and medications given in the office. The clinic also receives grants and donations each year. And I obtained this information from Kentucky's Medicaid and Medicare fee schedules and from the billing clerk at Hayden Family Healthcare. The first year, the salary would be $152,938, and I obtained these amounts from salary.com. I included a salary for myself, a medical assistant, and 1/3 of the salary for the receptionist, and also a portion of the salary of the human resources coordinator who takes care of the credentialing process. Total yearly expenses for the first year are $169,158.15. Salaries are a bit higher for the second year as a portion was given in consideration for staff raises. Much of the information regarding rent and utilities were obtained from the office manager. However, I also spoke with representatives from local insurance companies and did an online search regarding workers' comp and unemployment insurance in small business. So by joining Hayden Family Healthcare, the first year would cause a projected loss of $6,036.70. However, the second year is a bit more profitable with a projected increase or income of $10,826.41. This is due to increase in patient numbers and less expense due to equipment cost and office supplies. Adding another family nurse practitioner to Hayden Family Healthcare is essential to meeting the community's needs. This rural community is medically underserved and years of life are being lost due to premature death related to obesity, smoking, heart disease, diabetes, and cancer. Much of the community's hospital stays and health needs could be prevented by education and health promotion, disease prevention, anticipatory guidance, and disease management. By using these core competencies and evidence-based care, I can begin to help my community by addressing these significant concerns. And those are my references. And I'm done.
All right. Good job. Good job, Risha. You went a little over, but so it is sobering to me. I mean, I've been, as I told you, I've been on faculty at Frontier for a long time, and I've been to Hayden many times, and I've heard, that about the healthcare needs of the community. It really is sobering to me to hear how much need there is. I mean,
yeah, and it was surprising to me, because I see it and I know, but to actually see the numbers.
So even for you,
it really
it's
is
surprising to see. Yeah. Like, I mean, the premature death rate 3 times the national average. The ratio to primary care provider is like 5 times as many people. I mean, there's a huge need. It's so yeah, they do need more nurse practitioners. And then a piece of this proposal that we don't ask you to do, but you need to be thinking about, obviously, is all of you is how are you gonna grow the practice? Unless it's a practice that is really short-staffed and they're just bringing you in to take care of the existing caseload, most practices want to grow. So if you're going to see, by year 2, you're going to see an extra 3,000 patients a year, new patients, where are they coming from? And what is that outreach and what is that marketing? So yeah, there's a huge need in Leslie County. And then the other thing I just wanted to mention is, so the office manager says to you that they don't bill for procedures like I&D or cerumen removal. And if that's what they told you, I mean, that's fine. You're not going to get like points off for that. That's what they told you. But that's lost revenue. I mean, as you guys began to see, when the amount of money that providers get paid for medical services is really low in general, if you're billing insurance. And we have to be smart about getting as much as is legally, ethically due us. And so it's not just to include procedures you could bill for just in the office visit is lost revenue. And I think all of us in practice need to pay attention to say, you know, are the billing and coding people maximizing what you're doing, you know, and to not bill for something that you could bill for. Now I noticed, Rita, that like 85% of the patients are Medicare and Medicaid. But I'm pretty sure you really could bill for those things. I don't know for positive, I'm pretty sure you can, but, you know, and then particularly when, I mean, commercial insurance in general pays more than Medicare and Medicaid. So if you're dealing, you know, if you're a nonprofit organization, you're dealing primarily with low-income people that are on federal programs, you have to pay attention to every dollar because the reimbursement's so low. I'm curious to talk to all of you to hear what an average office visit around the country is. And with today's very huge uncertainty in what's going to happen with healthcare, I mean, it could get a lot worse, you know, so every penny counts. So, okay, next, Sarah.
Hi there.
Hi, Sarah.
Okay. Hi. All right. Do you see my screen?
We see your screen and we hear you. So begin whenever you're ready.
All right, wonderful. Well, hi, my name is Sarah Grable, and I'm a student women's health nurse practitioner. I am proposing adding myself as a new WHNP to the existing practice of Flint Hills OBGYN. They actually just recently lost a physician, so it took the practice down from 3 providers down to 2. So adding myself to the practice will help alleviate the really heavy caseload of the current certified nurse midwife and the physician, and also increase the availability for appointments for new and existing patients. Flint Hills OBGYN is a pretty small clinic. It's located in rural Junction City, Kansas in Geary County. It serves the women of Junction City, which has a diverse population of approximately 25,000 residents. Women from nearby rural communities and the Army installation of Fort Riley also seek care there. According to the county health rankings compiled by the Robert Wood Johnson Foundation, Geary County's community needs are as follows. The STI rates are actually improving, but they're still pretty poor, with a rate of 634 new chlamydia cases per 100,000 people, compared to Kansas' rate of 381 and the US top performers rate of 134. Teen birth rates are also pretty high, with 74 cases per 1,000 compared to Kansas' rate of 38 and the US top performers rate of 19. The HIV rate in Geary County is also pretty high, with 160 cases per 100,000 compared to Kansas' rate of 119 and the US top performers rate of 41. Adding myself to this practice will allow more patients in the community to be seen, treated for, and counseled about STIs and HIV. I would also advocate for same-day LARC insertion, which would aid in preventing unplanned pregnancies and decreasing the teen birth rate. This clinic's mission statement aligns pretty well with both the National Organization of Nurse Practitioner Faculties and the ACNM's core competencies. It states that it's dedicated to providing compassionate, high quality, and individualized obstetric and gynecologic health care for their adult and adolescent patients. Flint Hills OBGYN is a professional association, or a PA. It's pretty similar to a corporation, but PAs are typically reserved for certain professions, such as for doctors or lawyers. The benefits to a professional association include limited liability, which would protect the shareholders' assets. They can raise funds by selling stock. They have lower tax rates, and they have the ability to offer competitive salaries and benefits. This clinic practices under a shared practice model where there's a distinct physician caseload apart from the APRN caseload. Practicing as the WHNP at this clinic would align with the Institute for Healthcare's Improvement's triple aim providing better and affordable care that improves population health. I would increase the availability of care to this rural and underserved population and provide safe, efficient, patient-centered, and evidence-based care while empowering women to be advocates for and partners in their health care. All of this combined would lead to the improved health of our community. Based on this clinic's visit numbers from 2016, and after interviewing the office manager and my current preceptor, it's estimated that in my second year, I would see 480 new patients, 180 return or follow-up visits, 480 wellness visits, 480 OB visits, and 240 sole contraceptive counseling visits. The top 3 most provided procedures are IUD and Nexplanon insertions and IUD removals. In 2016, the entire practice only performed 156 IUD insertions, 64 Nexplanon insertions, and 58 IUD removals. So it's estimated that in my second year, I would perform 96 IUD insertions, 40 Nexplanon insertions, and 36 IUD removals. Expenses are pretty high, and the figures on this slide represent my second year. Expenses were calculated after interviewing the clinic's office manager and the billing specialist. They also provided the figures necessary to calculate my revenue, which will be seen on the next slide. They were really open with the costs of running the business, which was really pretty eye-opening for me. Personnel expenses include all salaries for myself, a portion of salaries of 1 receptionist, 1 medical assistant, and 1 office manager, along with taxes, benefits, and professional development fees. Operating expenses include facility fees, supplies, medications, and the billing service. The total expenses for my second year is around $224,000. Now, here is a breakdown of my second year revenue from approximately 1,860 patient encounters, with 25% Medicaid payers and 72% commercial payers. The clinic doesn't have an in-house lab, so diagnostic procedures are pretty limited. The total revenue for my second year would be around $250,000. So on this slide is my profit and loss evaluation for my first and second year, which takes into account a 5% uncollectible revenue. They actually have a pretty high claim collection of about 85%. And this also includes a 5% net margin of error in expenses. As you can see, my first year would not be profitable, and we'd actually have a loss of around $25,500. And the second year improves with a gain of just below $3,000. I do want to note that in this practice, everything is already established. No new personnel would need to be added, such as a receptionist or medical assistant, since there are enough there to handle the extra caseload that I'd be bringing in. But profits would continue to increase as I generate more patient encounters and begin to perform more advanced skills, such as colposcopies, which is something that I would like to be trained in. A full-time women's health nurse practitioner would benefit Flint Hills OBGYN by not only providing more accessibility to appointments for our patients, but by also attracting new patients to the practice. Providing quality, efficient, effective, safe, and patient-centered care will improve the population health by focusing on and addressing our community's needs. Since APRNs provide cost-effective and quality care, increased numbers of APRNs in practice can increase healthcare accessibility. I urge all of you to support the continued efforts of APRNs to advance our profession by advocating for our ability to practice to the fullest extent of our education and training. Here are my references. I am done.
Good, Sarah. So nicely done, just under 7 minutes.
Thank you.
So you're suggesting an existing practice as well. So all of you so far. Okay, so Ashley, we'll talk to you in a minute and see whether you're going to create something totally new. But joining an existing practice, and replacing a physician with a nurse practitioner. So they had a physician leave, and your idea is to add a nurse practitioner. So far, you and Colleen both talked about joining for-profit corporations. The other 3 were all not-for-profit. And so one of the things to think about if you're going to join a for-profit corporation is there a way to have ownership in it? And do you want ownership? You know, so as an LLC, you could be you could in the future become one of the owners. As a professional company or corporation or whatever they called it in Kansas, in most states, you can have more than one type of profession. Like I was in a practice for many years where there were physicians, like OBGYNs and nurse midwives, and we both had ownership. And that's both a plus and I mean, you take the risk. It's like, okay, if there's not enough money, you're the last people to get paid because you're the owners. You know, you got to pay all your staff first. On the other hand, you have more control and power, and it's kind of fun. So I have been an owner in a practice, physicians and nurse practitioners, and also in an LLC that does that. So I've personally been in both models. I wouldn't suggest doing that your first year or two. You want to make sure it's a healthy organization that you want to be in for a long time before you decide you want to actually have ownership, not just be an employee. And Sarah, you mentioned the idea of wanting to do advanced skills like colposcopy. I think there are actually probably more of those for women's health than there are for basic primary care, but both learning ultrasound for early ultrasound for pregnancy and colposcopy for GYN are both revenue producing skills, and they're fun, you know. So you have to graduate first and then go out there and learn how to do that. But you know, that's something that you might want to negotiate with, you know, if they're going to hire you. Say, I want to learn this, and will you pay for me to go to, you know, additional training? And you can do a little business plan on that. You know, what will it cost them to train you, and how much by you doing that and doing it really well, obviously. Non-stress tests are another example for if you're in an OB practice that you can make some money on. Okay, Ashley, are you eager to get yours done and over with?
Yes, I am.
Okay, well, it's your turn, and then we'll all take a quick break.
Okay, can you see?
Yes.
Okay. So I'm also proposing to add myself as a second midwife to the Women's Pavilion PSC in Owensboro, Kentucky. It's located in Western Kentucky. They currently have 2 physicians, practitioner, a PA, a women's health nurse practitioner, and then just the 1 midwife. So community needs are to reduce sexually transmitted infections, namely chlamydia, teen birth rate, and low birth weight babies. Here you can see the incidence of chlamydia in Davis County, which is where Owensboro is located, had 405.7 cases of chlamydia per 100,000 people. So we're doing better, but we still have work to do. Teen birth rate in Davis County is 52 per 1,000. That's higher than Kentucky and the United States. In the incidence of low birth weight babies, Davis County had 8% of babies born weighing less than 2,500 grams, slightly less than the state average and slightly more than the United States. So the mission statement I adapted from the Women's Pavilion's current mission statement to put emphasis on midwifery. The Women's Pavilion PSC of Owensboro, Kentucky is a personally owned corporation. We strive to provide the highest level of patient-centered, evidence-based obstetrical, gynecological care and surgeries, primary care, and full-scope midwifery services to all women with our highly skilled healthcare professionals and state-of-the-art technologies. The legal structure
is personal service corporation. So they have decreased financial liability. They share the costs of running the business. They generate more money because they're personally owned and they own the business. They're the boss. And they have corporate tax, which can kind of be a double-edged sword, but they get taxed first for their salaries and bonuses, and then get taxed at a lower rate for like use of equipment and all of that they bill for. They attract employees because they can provide competitive wages and benefits and potential to share in ownership. It's expensive and it takes a lot of time to run a personal service corporation. They have to answer to state and federal regulating bodies, so it increases their. And so my program plan service is to add a midwife. 73 births per 1,000 women ages 15 to 44. So logically, they need another midwife. This increases evidence-based practice, continuity of care, more midwives to share the workload, their call to see more patients, offering more appointments and more clinic days, and provide services to a vulnerable population. Projections. So Owensboro has a population of 58,042 people. And last year we had 1,331 births. Approximately 700 of those births were attended by a provider from the Women's Pavilion, which is just the 2 physicians and 1 midwife. They delivered 119 babies, did 816 GYN well woman visits, inserted 146 IUDs, 107 Nexplans. So 82% of those patients are Medicaid patients and 18% commercial. And I got this information from the midwife, which is actually my personal provider, and I did some hours with her, and their office manager. So if I could potentially increase these numbers by half as I gain more experience and increase the patient load. So Kentucky itself is 21% Medicaid, and so a lot of it is in Davis County, so 82% Medicaid rate, which the physicians put a cap on what they accept and the midwife doesn't. Revenue projections. The global fee for prenatal care and birth paid by Medicaid is $2,405. Well woman visit paid by Medicaid is $58.05. IUDs, they pay $59.25, and they pay $86.88 for an Nexplanon insertion. So to add a new grad, another medical office assistant, and credentialing, insurance, and all of that, the total was $167,860. And so I projected mine over 5 years because I want to show them this in hopes they hire me. So if the cost is $167,860, in 5 years, if I double the numbers that my midwife did last year, within 5 years, that's the number of experience that she has, then I could bring in $388,237 in Medicaid patients alone for a total profit of $220,377 in 5 years. So, in conclusion, adding a second midwife to the Women's Pavilion would increase access to evidence-based full-scope midwifery care in Davis County, Kentucky. By increasing midwifery care, we would decrease the number of sexually transmitted infections, teen births, and the incidence of low birth weight babies. Increasing access to care, providing midwifery-led education, and providing adequate birth control for all women. There's no references.
Nicely done, Ashley. I love that you actually went ahead and looked at 5 years. I mean, for this project, we only ask you to do 2 years, but realistically, it's often year 3 that you start really bringing in a profit, depending on how you divide all the expense side. So I love that you went ahead. So while I'm thinking, let me say one more thing, and then we really will take a really quick break. So it's interesting. So I have been doing these seminars for a couple years now, and I think this is the first time that everybody did as you did, which is add a new provider to an existing practice. And I have no objections to that. I mean, that's probably, if I were doing this exercise, it's probably the one I would choose too, because it's probably the easiest. Not that this was easy, but anyway. But so for all of you, I would say if you're really going to do this, if you're really going to make a pitch for a position, that one of the things that would be helpful to add is something special, something unique, an idea that you have about how you and the practice can personally address something. So not just that because the data on advanced practice nursing is so good, they should hire you. But, so like several of you have talked about high teen birth rates in your communities. So what innovative could you suggest to them? Some ideas, like, maybe you could do a partnership with the local high schools or with the teen, a rec center, or, where are these kids? Where are these girls that are getting pregnant and having such high STI rates that some of you have mentioned as well? And, what kind of outreach could you do with them? And to try and prevent the STIs and the pregnancies, and then maybe have a teen clinic. Like, maybe 1/2 day a week, you only see teens, and that would bring them in, because teens are really hard to deal with and they don't like to come in for care and blah, 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 so come up with something, innovative in that way. If because part of, so when you're making a spiel for creating a position and hiring me, I mean, bottom line, you want a job. And I get that. That's totally okay. You want a job. You just got out of grad school, you got debt, you want a job. But if you can add something that's bigger than just you, it sounds less self-serving, and I think it becomes a little bit more compelling. So that's just, a strategy for getting a job. So you all did great. You all passed. All right. So I want you to relax. And it's about 9:15 on the West Coast. So let's take like 3 minutes. Just get up and stretch, get some coffee, whatever you want, and then we'll come back and we'll talk for about 45 minutes. All right. Okay. So come back. You're not done. I'll be back in a minute too. Okay, so Carly and Ashley, are you back yet? It's just been 3 minutes. If you are, put your video on. There's Ashley. So we're just waiting for Carly. All right, so you're all back. Okay. So here's what I want to do next. I want to go around the room in exactly the order that you presented. And I have 2 questions for each of you that I want you to answer. One is, are you serious about the proposal that you just made? And what surprised you most about doing this exercise? So let's start with Kate. So don't forget to unmute yourself because you're all muted.
Yes, I'm serious. Although I don't know how interested they are in hiring me, really, because they have a lot of midwives in their group, and I don't know if they really see themselves growing that much more. But I'm definitely serious. I would love to work for them. The thing that surprised me the most was the amount of revenue that they were able to reclaim. You know, the fact that over 40% of what they charge doesn't come back to them. They never even see. And I know we've talked about that in other classes, but for some reason to see it in the stark numbers was really, really surprising. I mean, I was thinking, oh my gosh, I'm marketable. I'm gonna make them some money. I was thinking really good things about myself. And then I put that loss in, and it was, wow. I mean, it makes a huge impact, and what a weird business model it is that is how it works, and that's just the way it is, and insurance companies just don't pay sometimes. I mean, just bizarre to me. So
yeah,
that was the most surprising thing.
Yeah, it's a totally bizarre business model. I mean, that you know, you provide a service, you develop a charge for it based on your expenses and kind of what the going rate, and then people don't pay that. You know, they like discount it a lot, you know, and yeah, so you found that in that practice in Portland that it's they collect about 60% of what they bill.
Yeah.
Yeah.
So
yeah.
and then when I thought she was exaggerating. And so then I went online and did a little research, and it seems like between 40 and 46% is pretty normal. Like, that's uncollected revenue.
Yeah.
The average practice. So then I just took 43 as just kind of
No, I think that's about what I hear nationwide. I mean, I think I may know this. I also teach nationally, I teach the How to Start a Birth Center workshops for the American Association of Birth Centers, and our CNEP students go to that. So I may have met some of you there. And so I always ask, around there. And I think, yeah, if you can collect 60 to 70% of what you bill, that's good. Unless you're doing a cash business, which many of you, or which not many of you, which increasing numbers of primary care providers are doing. It's like, why should I work so hard and then have to discount my rates 40%? If you're only doing office visits, doing a cash only business and keeping that money is a model that more and more NPs and physicians are considering. Anybody who does a big ticket item like surgery or births, it's hard to do cash only because people can't afford to write a check for $5,000 to you, but they can write a $100 check for an office visit. Some people, not all. I mean, obviously, really low income people, that's totally out of their reach. All right, Carly, are you going to try and get this job in Erie?
Well, I would ideally like to work in a family practice, but I don't think that they're going to be hiring right now. I work in labor and delivery. My background is pretty much women's health focused, but I decided to do family to make myself a little bit more marketable, I guess you could say. And there's a opportunity for me to join a new OBGYN practice. So one of the doctors is actually talking to me about that currently. So I don't know, we'll see, but it's definitely a lot going into it. I was just talking to the one physician who's going to open up a practice here this year. And I was just like, well, I just did a project on it. And it kind of sounds like it's a lot of work. So.
And what about it surprised you?
I guess just the cost for everything. I mean, obviously for my project, the equipment and things like that were pretty much already provided, but even just like the practice that I'm at currently has 8 exam rooms. So just to the cost for one exam room is just kind of like crazy to think about. That was pretty much just how much goes into establishing a practice. I mean, it sounds kind of like, oh, okay, like there's a need, I can do this, but also, starting a business is a lot of work in general.
Yeah, and so, I mean, I think it's great that you have the big picture. I think as somebody who is enthusiastic, a new graduate, excited about making a difference in healthcare and wanting to get a provider level salary, it's really helpful to balance that with humility and gratitude that somebody has come before you and created a practice. And that took a lot of risk. It took money. It takes a lot, and to be able to share that recognition and share that awareness and actually talk about the business side. It's how much, I feel like I'm worth this much. Is this a practice that can afford, to pay me that? You want to join a practice that's financially stable. Although, once again, I think nothing is financially stable right this minute. So it's you're all graduating at a very dynamic time. So that'll be, but keeping your eyes open is super important. Colleen, Delaware, are you gonna get them to add another position?
I actually, when I was talking to the office manager, I kind of was like, oh, what do you think the chances are that, I could get a job here? And she said, currently we're not, actively, we don't have room for another provider right now. However, one of the midwives, actually my preceptor, her daughter has such extreme asthma that her doctor basically said they need to move to a warm area because it's cold induced. So she's actively looking to move with her husband and family. So I'm like, kind of like, oh, I like her, but at the same time, that'd be great if she left because I could just slide right into her position. And then one of the other midwives, not my preceptor, so I said there were 3 midwives there. 2 of them are my preceptors, 1 is not. And the one who is not, the other 2 say that her productivity is so just down in the dumps that they just can't believe that she's still working there. So I'm like, oh, there's another potential if she was to, you know, be asked to leave or whatever. So I'm kind of, I really would love to work there, but I don't know. I guess it kind of depends on what's going to happen over the next couple months to a year with these other 2 midwives and whatnot. But yeah, I mean, I still am trying to, you know, suck up and see who I need to talk to. I mean, I seem to get along with everybody there and they seem to accept me and I'm there all the time. So they all know me by name and face, all the doctors and all the nurses and MAs and everything. So I would slide right in nicely. So it's just a matter of making them see that it's worth it.
Yeah. You know, being able to get a job at a site where you're doing your clinicals has obvious advantages. I mean, first of all, you know what you're getting into because every practice has its own culture and its own personalities and its values. And like, do I really want to work there? I mean, that's a really important question. And they know you, you know, and as we've talked about, to hire a new graduate, well, to hire anybody new is expensive. It takes a while, even if you're an experienced provider, to recruit you, to credential you, to orient you, and then to sell you to the patients and to build up a practice and all that. So any new provider is going to cost a practice something. And then a new grad, the expectation should be that you don't see as many patients, especially the first, 3 to 6 months, because you have to get your skills up a little bit more. So, so you don't want, what a practice really doesn't want is to hire somebody and then find out it's not a good fit.
Yeah.
It's like, that's super expensive and super disruptive. And, so they know you already and you know each other. So the good fit piece, you already know when you're a student. So, that's
half
a real,
the battle.
Yeah. All right. Okay. Who was next? Rita. Are you going to be able to join this practice in Hayden, do you think?
I would love to. My preceptor actually has mentioned that to me. They are actually down 1 nurse practitioner, but the patient load, is pretty low. But they have a provider who is looking to retire in the next few months. And she's also a psychiatric mental health nurse practitioner. Mm-hmm. So she's maybe going to focus more in that area. So my preceptor has, hinted to me and mentioned joining, and I would love to.
Yeah.
It's a small clinic.
I mean, that your comment that the numbers are kind of low, is a conversation you really have to, obviously somebody has to have, like, are there enough patients to support adding you? And if they're not, eventually you're going to lose your job because who's going to pay, who's going to pay? You have to bring in some income. But can you, what is the marketing? What is the outreach where they can bring patients in? I mean, the data that you gave about the ratio of primary care providers to people in the county suggests that people need care. So how can you get them to come to you? And that has to be a marketing outreach plan, and so, okay. And what did you learn that surprised you in thinking about making a proposal to this practice that you want to share?
I think what was most surprising to me is, just like some of the others had mentioned, just the cost, because I had never thought about workers' comp insurance or unemployment insurance that you would have to provide, the taxes, just the cost of everything really surprised me and opened my eyes to other things that you have to look at other than just caring for patients. because that's what I've been focused on, as a nurse, and didn't really look at the money side.
Of course. Yeah. Yeah.
So
Yeah, it really,
I don't like this part of it.
Huh?
I don't like this part, the money part.
Yeah. So I think most healthcare providers don't like the business part. And I think that's totally okay. You don't need to like it. But what we do need to do is be aware that it also is a business, especially in the United States. If you worked in Canada or in the UK, where there's or almost anywhere else in the world, in developed countries where there's a national healthcare system, even that is a business, but it's supported nationally by the government. And but in the United States, it's in the for-profit world, even if it's in a nonprofit. And so you have to pay attention to productivity, to utilization. How many patients are you seeing? One of the ways, the things I like to say is that a way to know who's paying the bills is to have a busy clinic day. And let's say there are 3 providers in the office, and each one is supposed to see 20 patients. And so there should be 60 patients coming in that day. And there's a snowstorm, and you got 30 of them that don't show up. So you got a 50% no-show rate. So how does everybody react to that? So the receptionists, the front office is delighted because they don't get to see they only have to see half as many patients. The MAs are happy. The providers that are getting paid a salary are perfectly happy. It's like, that's fine. But the business manager, and the providers, if they're paid on productivity, it's like, oh my gosh, I only saw half as many patients. It may affect your paycheck. And so when you guys are all doing your interviewing and finding out about jobs, you want to find out how you get paid. You're probably not going to get paid an hourly rate like you did as an RN. Now this is different payment methodology, and there's all different kinds, whether it's straight salary or salary plus a productivity bonus, or based totally on productivity. Does anybody know if any of their preceptors are paid on productivity only? No. Okay. As a student, you get to ask the most amazingly personal questions. And somebody was saying how she was surprised at how open the office manager people were about sharing information. It's because you're a student. You just go, oh, I'm a poor student, I have to graduate, and they made us ask this question, how do you get paid? And what advice do you have for me about, when I go out into the workforce? But more and more practices are paying based on, at least a component of the salary is based on productivity, and that's often measured by RVUs, relative value units. Anybody not know what an RVU is? Is that in this course? And then, let me tell you real quickly, because I think this is important. So every procedure you do, or every service you provide, has those 2 codes, right? The ICD-9 code and the ICD-10 code and the CPT code. And the CPT code is the procedure code. So it's an office visit like 99214, or it's a Nexplanon removal. Okay, so they each have a code, and there's a bill, a charge attached to that. But there's also an RVU, a relative value unit, attached to that, and these are federally published numbers. And so somebody has spent a lot of time trying to figure out how much value is there in that service. So a more complex office visit will have more RVUs than a simpler office visit, and a new office visit will have more RVUs than an established patient, right? So somebody in your practice is tracking all the charges that go out in your name, and all the money that's coming in your name, And they're also tracking, or should be tracking, the RVUs that you're generating. And many, I don't think it's most, but many practices are moving towards paying their providers, at least in part, based on how many RVUs you generate. So it's a concept you need to know about. Weird, huh? It's really not like being a nurse and getting paid hourly and then time and a half if you work overtime and, you know, extra when you work on nights and all that. It's just a whole different thing. And hopefully this exercise helps you understand the complexity of all of that. Okay, Sarah in Kansas. Are you going to try and join these OBGYNs?
You know, I would love to. And they actually approached me about a month ago asking if I'd consider joining them. They're pretty stretched thin with the loss of that physician last year. But my husband, he's in the Army, and we are planning on moving this summer. And so they asked if I'd be willing to stay, you know, here while he went on to our next duty station. And, you know, honestly, if they paid enough, I would consider it. But it's a small little practice. I love it there, and I love the community that we serve. If we were staying here longer, I would definitely stay. I would love it. They're wonderful there.
You know, if you have the opportunity to sit down and talk to them about it, take the opportunity.
Yeah.
You know, it'll be a learning experience. I mean, you know, you're obviously being upfront. It's not a long-term thing, but if you would be willing to consider staying for 6 months or a year, you know, since they know you and everything, you're already halfway oriented.
Right.
You know, they might be, and it would be very interesting for you to see what they would offer and what it would look like and so on. Huh.
Yeah. Yep.
Yeah. So did you learn things from the business point that you had no idea of, just being a clinical student in this practice?
Oh yeah. Yeah. So doing this, I looked up the Medicaid fee schedule for Kansas and plugging them into my Excel worksheet. And then I went to go interview our office manager and the billing specialist. They're like, what, where'd you get those numbers from? Because they were so much higher than what they actually get reimbursed. Like probably even double what they actually get reimbursed. So that was pretty eye-opening for me to see that, like the Medicaid fee schedule, yeah, it says, you know, you'll get $150 for this type of visit, but they're only getting 75 or something. It was pretty eye-opening.
Yeah.
And then it takes sometimes 6 months to get paid from sending out their bills. But they do have a really high, what am I trying to say? Collected bills. So we were talking about how a lot of places only get 60% of bills paid or charges sent out that are paid. They actually get right about 95% because they're pretty proactive about sending out collections to get paid, because it's a pretty small practice.
So what they're getting paid is shamefully low, but they're collecting what they are due.
Yes.
Right?
Yes.
Yeah. Does Kansas have managed Medicaid? Do you know? I mean, are there different companies that offer Medicaid within?
Yes.
So
so there's
So many states are moving to that. So the published rates are like state Medicaid, but more and more states are going to manage care through their Medicaid. So different provider groups get together and bid for that contract. And in order to get the contract, they have to discount their rates. And so that's where it drops even more.
Yeah, it was pretty eye-opening to see.
Yeah, it's a difficult business, and it varies widely from state to state. I mean, like Alaska, Medicaid reimbursement is really good, and then some states are really bad. I mean, it just and then depending on if the state has managed Medicaid, depending on which contract you have, it'll really make a difference as well. And in general, as I said, you get more from the commercial payers, but not always. You know, so that's why it's so variable. And it's also why, let me say one more thing before we go around to Ashley. I really think it's okay to ask, as an advanced practice nurse or a midwife, for financial reports for your practice. I mean, in most of the practices I've been in, that has been the way it's done. So we would get a monthly report that showed financial information for the practice as a whole and for you as an individual provider. So how much was billed out in dollars and cents, how much was collected, which is really the important thing, and what are the expenses that are allocated to you. And because if you're working really, really hard and seeing a lot of patients and generating a lot of charges and thus RVUs, but your billing and collecting people aren't collecting it, then bottom line, it looks like you're not bringing in enough money to even cover your expenses, and your job is going to be vulnerable. And it may not be that you're not working hard enough, but that the billing and collecting people aren't doing their piece. And so I think that I know it's okay to ask if the practice provides that. Some do and some don't. But, you know, again, as a new graduate, you could say in school they told us, you know, that to ask for this kind of information, because you want to be, I mean, the message is you want to be responsible and you don't want to be naive. I've just heard too many stories of providers who say, oh, well, I have this great salary and, you know, I only have to see 10 patients a day. And then, you know, a year later, they don't have a job anymore because they haven't been paying attention to the money side of it. So, you know, or they're allocated in a bigger practice. Each provider may be allocated so much overhead expense that it looks like you're losing money, you know, and, you know, we don't get to do the expensive procedures. And so we can't generate as much money as somebody who's doing surgery, you know, for example, you know, which is why a lot of practices, or some practices, try and figure out strategies to bring in extra revenue other ways, like doing, you know, Botox. You know, that's like a cash supplemental business. It's just a way, I mean, especially in women's healthcare, you see a fair number of OBGYN practices doing skin care, and it's really just to supplement, to get some cash in. It's all a little strange. Ashley, hey, are you going to see if they'll expand the midwifery practice there in Kentucky?
Yes, actually, before I even started this program, I had told my midwife, who I did some hours with her, and the doctors were like, oh my gosh, when are you going to be done? Because they have such a big, you know, there's 3 of them. They did 700 births last year, an extra set of hands.
Mm-hmm.
I think I don't have any labor experience, and that's going to hurt me in the long run. But I did show off how great I am as a cardiac nurse. One of the persons that work in the office, their husband was in. He was my patient. I was like, see, I mean, I can be really good. You need to hire me. I know there's a desk there. So I want to join the established practice. I don't have any desire to entrepreneur necessarily. So I'm hoping. The thing that I was surprised about, of course, was the money difference in what you bill and what you get paid. So their rate is $3,500 global fee, and mostly Medicaid patients, they get $1,100 less than that per patient. And there is such a delay from the time services are rendered till you actually get paid for that.
Yeah, you know, Ashley, that's somebody else mentioned that, and that's a really good point to make again. I mean, this sounds very cynical, but it's true. Insurance companies are in the business of delaying payment to you. You know, they collect money from all their insured, and it's sitting in their pockets, and then they can invest it and do whatever they're going to do with it. And they will, if there's any reason to delay paying you, they will. They'll reject a claim and send it back to you. And it's called like a dirty claim. I mean, even the language is weird, right? And so particularly for OB, it's a real problem, because often for OB, you don't get to bill for the birth. It's a total package. You don't even get to bill till the baby's born. So you're doing care for 7 months with no income coming in, which is, you know, so why you need some GYN business, and, you know, to be able to bring some cash in while you're waiting to get paid for those the births that you're doing. And then you bill, and it may be 2 to 3 months until you get paid, or you may not, somebody mentioned this already, you may not get paid at all. They may deny the claim, you know, because the person still doesn't have the insurance. Like the front office didn't get a current current card, you know, and they had insurance last time, but now they're back for follow-up and they don't have insurance, and you didn't pick it up, and so you don't get paid at all.
So when I had my daughter, I was 6-month-old, and my insurance company sent me papers asking me to fill them out, saying I didn't sue my homeowner's insurance. I thought, well, it's not the house's fault that I got pregnant, but that's a thing. I'm like, is this real? All because they didn't want to pay.
Yeah, no, it is. It's complicated, and so within the practice, somebody really needs to, again, be paying attention to coding and billing and maximizing that. And some practices outsource it to a billing and coding. So there's this whole specialty where you can get certified as a biller and coder. And, you know, Frontier just hired Joni Slager as the director of the DNP program. So for all of you who decide to go ahead and get your DNP, she's now the director, and Joni is a certified biller and coder. She's a midwife, but she's sort of famous within the midwifery world because she's written some books and teaches workshops all over the country about billing and coding. So aside from Joni, there are very few certified nurse practitioners and midwives that are certified as coders, but there is that expertise, but each of us needs to know enough about it that we know that whoever is working for us on our behalf to bill and code for our services is doing it correctly. Because way too much money is left on the table because they don't know to do it. It just, you know, there's many places. So optimizing your billing and coding is something you should pay attention to when you're in practice. You know, because we all, you know, I know we go into healthcare because of the mission, because we care to serve people. But if there isn't a financial margin, you're not going to be able to do your mission. So there's this little phrase, no margin, no mission, you know, which is just a shorthand way of saying we have to pay attention to the money so that we can keep doing the service that we want to do. And that's true even in a nonprofit organization. I mean, nonprofits are still a business, and they may be able to supplement the earned income from patients and from insurance companies by grants and donations and fundraisers and so on. So they have that cushion, but it's still a business, you know, and there's only so much grant money and donations. That's not a sustainable way to stay in practice. So either way, whether you're in the for-profit world or the nonprofit world, you need to pay attention to all of that. What else? So we've got a little less than 10 minutes. What did you guys learn about expenses, big ticket expenses? I mean, you've mentioned some of them. How about malpractice insurance? Nobody has mentioned that yet. Did anybody off the top of their head do you remember what it was going to cost for a policy for a new graduate? Were you able to find out? I mean, sometimes that's hard to find out, but was anybody able to find out in real numbers what 1 year of malpractice would cost for you? You know, everybody unmute for just the last 10 minutes so we can just talk a little bit.
I did. I Googled that, and it said $2,100 a year for malpractice insurance.
Okay, so you saw 2,100 for a nurse practitioner. Okay.
Yeah.
Anybody else?
I estimated 6,000
Okay, and that's for a midwife.
for a midwife, a brand new midwife, and that was based on just picking the brains of midwives I know, and they didn't really know what their malpractice insurance was covered by their employees, which I thought was kind of interesting too.
Yeah.
But that's kind of what I came up with. There's not a lot. You have to trying to find that information is really cagey. They want stuff from you, you know.
Right. Yeah. So that's and sometimes you're not going to be able to get it. But I think what both of you just said is probably about right. I mean, what I hear from people is for a new nurse practitioner, it's probably $1,000 to $2,000. For a new midwife, it's probably 5 to 8. I mean, so I think you're right, Katie. That's probably about what it is. And then, so for midwifery, I mean, obstetrics, it gets sued a lot, and so the rates are a lot higher, and they vary from state to state, and they increase over time which is a little bizarre. I mean, you would think that the more experienced you are, the less risk there would be to the malpractice carrier. But with OB, you carry that patient. You're increasing their caseload because they can sue up until the time they're like 18. And I mean, a practice that I started a birth center in Tucson 35 years ago, and ran that practice for almost 20 years. And about 20 years ago, I left a couple years after that. Our malpractice insurance, there were 5 midwives, and it was a small non-for-profit at that point. And I started it as a private practice. Another midwife and I did it, and then we hired collaborated with some OBGYNs, and we were a shared practice, and then we became a nonprofit. And so I was the director, and I was paying really close attention. And then I became president of the board. So the last year we were an independent nonprofit. There were 5 midwives, and the quote from the malpractice insurance carrier for the next year was going to average $40,000 a year for each midwife. 40,000, 5 midwives. And that practice, so that's $200,000, right? I mean, that's almost $250,000 every year for malpractice. And the practice had been in business for 25 years and had never been sued once. If you're ever sued, your malpractice goes way up, or you can't even get it. So malpractice is a big deal, and it's a particularly big deal for the midwives. Not as much for the nurse practitioners. But another thing you need to ask is, when you're thinking about a job, is there tail insurance, and do you have to pay for it? So the tail, if most malpractice insurance policies only cover you if you're working for that organization and you still have insurance with them. So if you leave the practice and 5 years later, again, this is more of an issue for the midwives, but also for the nurse practitioners. Let's say you leave a practice and the next year one of the patients you saw just before you left is diagnosed with breast cancer, and you had seen her for her annual exam, and she's claiming you missed it. Because breast cancer is another diagnosis that's sued about a lot. So all of you guys, have exposure to that. If you're no longer at that practice, unless they bought or you bought something called tail insurance, you're no longer covered. So you have to buy this tail insurance that carries you forward, that covers you even though you're no longer working there. And it's usually about twice your last annual premium. So, if you're hired and they're paying $2,000 for your malpractice and you want to leave the practice, somebody will probably, unless they have a special plan, but they may have to tell you, well, if you want malpractice, you have to pay this tail. It's going to cost you $4,000. For the midwives, if you've got a $5,000 premium and you have to buy a $10,000 premium, to buy tail insurance, that's a lot of money. I mean, I know physicians who have said, and cynically, and it's true, that they can't afford to quit because they'd have to buy tail insurance, $100,000 tail insurance. I mean, it's crazy. So that's another thing that you need to be sure to talk about when you're interviewing. Okay, what else? One last thing I want to say, and that's another expense item that's on that spreadsheet. I want to say two things. Okay, one of the things that's on that spreadsheet is collaborating physician. Some advanced practice nurses, particularly if they're in a private practice with only advanced practice PAs, nurse practitioners, are in communities where, in order to get collaborating physician coverage, they have to pay them. I think that's really unfortunate. Sometimes you have to do it, but if you're ever in a practice that's only advanced practice nurses, you want to learn a little bit about that. I personally think that we're independent providers. We shouldn't have to pay physicians, but we should refer. I mean, they're getting lots of referrals. That's where they're getting their money. So that's one thing I wanted to say. The last thing, and I promise this will be the last thing, is please give, so Linda Cole, Dr. Linda Cole is the a course coordinator for this course, and I think this is the third term that she has done it. This term, she completely redid the spreadsheet, and as she sent out an email the other day, there was actually a mistake on one of them. Linda is very, very open to your feedback about what was valuable, what wasn't valuable in doing this. We recognize it took a lot of work. We're trying to not have you waste your time researching lots of things, but we do want you to research some things. I mean, like that spreadsheet she made with all the expenses. I mean, she put that whole thing together so that you don't have to see how much an exam table costs. You just put in the number, I need 2 of them, and it adds it up for you. So there's a lot of work that's been done with those spreadsheets together. I'd recommend you take a copy and save it somewhere. A blank copy, you might really use it someday. It has all the formulas, and you could use it for your home budget. So it's a nice little tool. So take a copy of that, and please, at the end of the course, give feedback to Linda about what worked for you, recognizing that your primary focus is on clinical care and graduating, not getting your MBA. But as you said, hopefully your eyes were opened, and that will serve you well. So, anybody else have anything profound they want to say? All right. Well, thank you very much. You will be hearing from me over the next week with feedback about your stuff, and I wish you the best. I hope some of you get to come back for graduation in October. I know not everybody can do that, and sometimes it doesn't even make sense in your life. But if you do come, I will be there. Come introduce yourself to me, and so I can meet you in person.
Thank you.
Thank you, Catherine.
Bye.
Thank you.
Bye.
Wish you all well.
Bye.
Good day, everybody.
Bye.
Bye, everybody.
Bye.
Bye.